Hey everyone, it's Sarah, Registered Nurse RN.com, and in this video I'm going to be doing an NCLEX review over rheumatoid arthritis. And this video is part of an NCLEX review series over the musculoskeletal system. So be sure to check out those other videos. And as always, at the end of this YouTube video, you can access the free quiz that will test you on this condition. So let's get started. First, let's talk about what is rheumatoid arthritis, also called RA. It is an autoimmune condition, so the immune system is attacking the joint itself that causes inflammation of the joints. And specifically, that immune system is attacking the membrane lining the joint, which is called the synovium. So what exactly is a joint, okay? It is where two bones meet together. So if we were to illustrate a joint, we have our two bones, and this is where they are meeting together. And within this area is the joint. And let's go over the parts of the joint, the simple parts. First, we have this area right in here, this maroonish area, and this is called the fibrous capsule. And within that, we have that membrane in purple that is lining the joints. And this is called the synovium. It's connective tissue. And remember, in RA, this is the area that is getting inflamed. And look at it. See how close it is to the cartilage of the bone, to the bone itself. And after a while, it becomes so inflamed, it can cause complete joint damage and actually, which we're going to talk about here in a second, cause a condition called ankylosis, which will actually cause the two bones to form together. And then this area in here, the blue, is the synovial fluid. And this just allows those two bones to glide upon each other. Now with RA, this tends to affect all the joints, and it can also affect the system. In contrast with osteoarthritis, it tends to really only affect those weight-bearing joints. So let's see what's happening in RA. Okay, you have various stages, and one thing you want to remember with RA is that it's autoimmune, there's no cure, and we want to catch this early. And it's fairly difficult to actually diagnose, which we're going to talk about a little bit later. But within 1 to 2 years of the onset of this disease, this can actually start to cause joint and bone problems. So it's really crucial that the physician tries to catch it in the early stages so they can start taking medicines if it's really severe and performing some lifestyle changes to help preserve that joint. So what happens first? The first thing that happens is that you have inflammation of the synovium, also called synovitis. And what happens is that white blood cells, because remember this is autoimmune, start to invade the synovium, which causes that membrane to become thickened and inflamed, which over time will cause the bones and the cartilage to erode. Then it will lead to the next stage, and this inflammation that has occurred leads to the formation of a pannus. And a pannus is a layer of vascular fibrous tissue. And the pannus will actually grow so large, it will damage the bone and the cartilage within the joint. And then the space in between that joint will disappear, and we will progress to that next stage, which is called ankylosis. And this will develop, and what will happen is that you will actually have the fusion of the two bones together. And this will lead to major stiffness in the joints for the patient and severe immobility of that joint. And just to give you an example of this, over here on the left, you see a hand and you see the joints, they're normal, there's no inflammation. And notice the phalanges, they are straight, they're not deformed, they're not curved. However, on the right, this patient has rheumatoid arthritis. And notice that the joints are very inflamed and it's eroded the cartilage and the bone. And it's actually caused the phalanges, the fingers, to start to curve outward. And here in this patient, you can actually see how this looks in reality. And notice on this particular patient, the tops of their fingers are doing the curvature from where the RA has progressed to one of those latter stages. Now let's look at some quick facts about RA. Then we're going to look at our signs and symptoms, our nursing interventions, and the medications. Okay, RA tends to affect what? It most commonly tends to affect the fingers and the wrist joints. And it can also extend to the neck joints, the shoulder, the elbows, the ankle, the knees, and the feet. So one thing to remember with RA, it affects all the joints. All of them are in play for this condition. Compared to osteoarthritis, which we're going to talk about in our next lecture, this tends to affect really those weight-bearing joints. And RA just doesn't tend to affect joints. It actually affects the whole body, so it's systemic. It can affect the heart, the skin, the lungs. It can even cause anemia, etc. So it's going to be systematic wide in your body compared to osteoarthritis, which is just really affecting those joints. Now your patient, whenever you're looking at their joints, how are they going to appear? Well, the joints are going to appear soft. They will be tender to the patient, warm, they'll be stiff and swollen. Now, some things you want to remember about RA that's going to help you differentiate it between other types of arthritis. I would remember these because things like this like to pop up on exams. Okay, RA tends to affect the same joints bilaterally. This means it's going to be symmetrical in the body. So if the right wrist joints have RA in them, the left wrist joints are. It's going to affect the same joints on the opposite side of the body, so symmetrical, remember that. Another thing is that the stiffness and the severe pain that this patient's going to have is going to be worse in the mornings for 30 minutes or greater. So when your patient's getting up in the morning and they have rheumatoid arthritis, it's actively flaring up, they're going to have issues moving and getting around. They're really going to hurt for a while. They're going to have stiffness in their joints and have problems moving around. Or after periods of long inactivity. Another thing is that RA can happen at any age, and it can vary between 20 years old to 60 years old. That's the age group it tends to affect. However, on the contrast, osteoarthritis tends to occur in patients who are older, like 60 plus. And rheumatoid arthritis cases can vary among patients. Some patients can have chronic, severe cases that last for a lifetime, while some patients can develop rheumatoid arthritis. It's for a short time, but then they go into remission. And RA can come on suddenly or gradually. So again, it really varies on the patient. Now, unfortunately, there is no cure for RA, and the key is to catch it early in patients, especially when they're in those early stages, to prevent progression of joint damage, because this disease can really affect people's lives. It affects their self-esteem, it affects what they can do every day due to their joint immobility. So what's some treatment for RA? Some treatment includes medications such as NSAIDs, non-steroidal anti-inflammatory drugs, steroids like corticosteroids, and the drugs known as the DMARDs, which are disease-modifying anti-rheumatic drugs, which we're going to talk about in depth a little bit later. Another thing is surgery. In really severe cases, they can have surgery like a joint replacement, remove the joint, put in an artificial one, or another type of surgery called a synovectomy, and this is where they go in and remove the synovium, because remember, that is the part that is inflamed in rheumatoid arthritis. So they go remove that membrane lining the joint. Another thing is an arthrodesis, and this is short and simple, a joint fusion. And this is where they go remove the joint, and those bones are then fused together with a bone graft. And patients are educated how to manage their RA, and depending on how severe the patient has this, these management tips can go a long way, which we're really going to hit in depth in our nursing interventions. But to highlight them, they need to develop a rest and exercise plan. For instance, when the joint is really inflamed, they don't need to exercise that joint, they need to let it rest. But once the joint becomes less inflamed, they need to do regular exercise to support joint health. Also, joint support by using splints, like wrist splints if they have it really bad in their wrist, or using assistive devices like canes and walkers, or the little grabbers that help grab objects that are far off, or raised toilet seats to help preserve that joint. Also, staying healthy, maintaining a low stress environment because stress can increase flare-ups. And the cause of RA is not completely known. It's unclear. And it seems to be a genetic factor, and hormones seem to play a role in developing this. Now, RA is hard to diagnose because, especially in those early signs and stages with the signs and symptoms, those signs and symptoms can be similar to other diseases. So the physician can order some tests. So as a nurse, you want to be familiar with what may be ordered so you can educate your patient. The physician may order a rheumatoid factor, which will come back positive if the patient has rheumatoid arthritis. Also, an increased erythrocyte sedimentation, also called a sed rate, will be elevated, or a C-reactive protein, and this is just one of the proteins that will be present if there's inflammation in the body. Doesn't really tell us it's rheumatoid arthritis, but because they can use this for a lot of other diseases that causes inflammation, but if it comes back positive, it tells us that this patient has a lot of inflammation going on. That's the key in this disease. And an X-ray will show that there is joint deterioration. So whenever they look at the images, the joints will not look normal. Sort of similar to what we looked at on that one illustration I was showing you between the normal hand and then the other hand that had the rheumatoid arthritis. So now let's recap all those signs and symptoms and those hallmark findings that we just discussed about RA to help you remember for exams. Okay, so let's remember the 7 S's. Okay, the first S, sunrise stiffness. They are going to have, whenever they get up in the morning, that morning stiffness for greater than 30 minutes of those joints. The other S, their joints are going to have a soft feeling. So whenever you feel them, they will be soft. In addition, there will be swelling in that joint that will be warm, and it will be symmetrical. So it affects the right wrist. It's going to also affect the left wrist. So it happens bilateral on the body. The synovium is what's going to be affected and inflamed. That is what's causing our big issue, and it gets so bad that it thickens, and you can get ankylosis, bone fusion in those very, very late stages, and you get bone deformity. It's systemic, so it not only affects all those joints, but it affects the whole body. So your patient is going to, from all that inflammation, is going to have a fever. They're going to feel really achy all over their body, very fatigued. It can affect other systems like the heart, the lungs, the skin, and anemia. Anemia has been found with rheumatoid arthritis. Why is that? Well, due to all the inflammation that is in the body, this can cause the kidneys to not produce as much of a substance called erythropoietin. And we learned in a renal function video that what does erythropoietin do? It stimulates red blood cell production. So if you're not producing enough of this substance, you're not going to have enough red blood cells, so you're going to develop anemia. So that is one of the findings with that. And the last S are those stages. So how does it tend to progress? Let's recap. First thing, they get synovitis. That is inflammation of that synovium. Those white blood cells have attacked that lining, the membrane of the lining of the joint. It becomes thickened. Then what happens is that a pannus develops, which is a fibrous connective type of tissue. And what happens to that is that joint space starts to disappear, go away, which will lead to bone fusion, which is ankylosis. And then we get major deformity, and the patient has severe limited mobility of their extremities. So now let's look at our nursing interventions. What are we going to do for this patient with RA? Okay, some of our focuses are going to include managing the pain, not only with medications, but with non-pharmacological methods. What this patient can do during periods of when they have inflamed joints, and how to take care of joints that are not inflamed, leading to how to preserve joint function through resting during when they're having flare-ups, to exercising, keeping mobility in those joints. And especially this is important during those early stages to prevent any ankylosis that can happen later on. Also educating them about their medications, getting an understanding of how they view this disease, what they think the disease entails, how to take their medicines. Also assessing their mental status. Patients who have RA, especially those severe cases, tend to struggle with depression and have low self-esteem because this disease is life-altering. For instance, just doing simple tasks like buttoning up a shirt or zipping a jacket can cause immense frustration in these patients because they can have the deformities of the fingers as we seen in that picture earlier, and they can't grasp the zipper or the button. And teaching them how to use assistive devices that can help them do those things can improve and give them a little bit more self-control over their life, because now they can button up their shirt instead of always having to rely on someone else to do it before they could do it. And also just feeling constantly fatigued all the time, the anemia, the pain, they can't do what they used to do, they feel like they can never get anything done. This disease literally rules their life, and dealing with just the severe pain and the fact that there's no cure. So helping your patients think of unique methods on how to manage this disease can go a long way and help them feel a little bit better. Okay, so what we want to do is we want to assess those joints and going to be looking for those hallmark areas. And you want to further evaluate the patient by asking them specific questions. They're complaining to you of joint stiffness that they're starting to experience lately and a lot of pain and they're swelling. Well, you need to be asking, is it symmetrical? If it's affecting the right wrist, is it also affecting the left wrist? Because this can help you differentiate between those certain types of arthritis. And also, the stiffness that they're having, is it worse in the morning whenever they get up? And how long is it worse? Are they experiencing stiffness for 30 minutes, an hour onward? Could be rheumatoid arthritis. And also just having the patient tell you about the disease and getting an idea of what their understanding about the condition is. Are they aware that, this is life-altering, it just doesn't go away, we can't give you medicines and you're cured, there's no cure? And how do they know how to take care of the joints, because what this disease can lead to, and how to do that? And how to manage those flare-ups when they start happening. What do they need to do? They need to rest that joint instead of exercising it, and giving them some tips on how to deal with that. And some tips for taking care of those joints during those flare-ups include resting that joint. It's important that you tell the patient, don't exercise it, don't move it, just let it rest. And depending on the joint that's involved, they can use a splinting device. So say that their wrist is what's affected by RA, they can put splints on their wrist. This will help limit the mobility in that joint and allow it to rest, and it tends to help with the pain as well. Also, they can do non-pharmacological methods like heat therapy. This includes like heating pads or a nice warm hot shower, and this is great for when the patient is having joint stiffness. So if your patient is getting up in the morning, they're super stiff and it's hurting, it'd be good for them to take a nice hot bath or shower to help alleviate that, along with cold therapy. And this tends to help with the pain and the inflammation going on. It helps decrease that inflammation with the cold. Now for the patient, let them know it is very important to have physical exercise. And a lot of patients, it's really hard to start doing this because they're tired already, but it actually helps decrease fatigue along with increasing muscle strength and preventing those joint contractions because it promotes joint strength. So telling them to do that regularly is very important, but it's also important that they don't overexert themselves, because say they're feeling great one day and they're going to do a little bit more than normal. Don't overdo it, because you can actually set yourself back, cause some flare-ups. So they want to actually have periods where they schedule for rest and then have physical exercise and to take it easy. And some exercises they can do, it's really important they do those range of motion exercises, moving those joints around, and low impact aerobic exercises. And this includes things that are easy on the joints, but are moving and getting our heart rate up, like the stationary bike riding, walking, water aerobics, things like that. And as a nurse, you want to be monitoring the patient and having the patient monitor themselves for signs of anemia. And remember, that's where your red blood cells are low. So all of a sudden, they're just really pale looking, they're really tired, they get super short of breath while just doing little exercises where normally they're not, because remember, red blood cells help transport oxygen through the body. And so what can be prescribed for that? Physicians may prescribe supplements to promote Red blood cell production like folic acid, iron, vitamin B12, because that helps promote the production of red blood cells, or maybe in those cases where the erythropoietin is low, they can administer that. And patients are, just since we're talking about anemia, they're at risk for GI bleeding. And why is that? Because a lot of times they're taking NSAIDs regularly, like ibuprofen, and these are really hard on the stomach, so they need to be monitoring themselves for potential GI bleeds like dark tarry stools, things like that. Now, RA, whenever the patient is admitted, it's going to be a multidisciplinary thing. You're going to have a lot of other disciplines on board, like physical therapy, occupational therapy, who's going to be helping the patient, evaluating the patient, and being part of that treatment plan. Now, assistive devices are very important for the patient with RA because they help alleviate stress on those joints. So as a nurse, you want to make sure that your patient is using that device correctly, because sometimes these devices can actually cause more harm if they can't use them correctly. That can cause them to fall, and that can cause them maybe to break a bone or something. So tools that they can use are those tools that can grab things that are far off, tools to help button and zip up the shirts, raised toilet seats, walkers, canes, things like that, and let the patient know that these things are available for them to use. Now, let's switch and look at our medications. What is prescribed sometimes for patients with RA? Okay, usually, depending on the patient's case, there will be like a combination of drugs. They may be on NSAIDs along with DMARDs, things like that, and each case varies depending on how the patient has this disease. So, first category of drugs is called the NSAIDs, those non-steroidal anti-inflammatory drugs. Popular drug, ibuprofen. And what does it do? It helps decrease that inflammation, because remember our synovium is inflamed, and helps alleviate that pain. But these drugs can cause GI upset. So it's important that you give the patient this medication with food, or tell them to take it with food, never on an empty stomach. Another category of drugs are called corticosteroids, and these decrease inflammation in the body. We talked about these really in depth in our endocrine series. And there's various routes that they can give corticosteroids, like by mouth, IV, intramuscular injection, or they actually inject a shot in the joint of a corticosteroid, or topical. Things you want to watch out for this is that, it can really increase blood sugars. So if your patient's diabetic, you start seeing like 400, 500 blood sugars, and they're on corticosteroids, could be our cause. Another thing is, it's hard on the skin. If you've ever seen a patient who's on steroids, especially in cases like COPD or things like that, they're on steroids a lot, they will have this thin skin, and it tears so easily, and it bruises. So you really want to make sure you have meticulous skin care with these patients, because not only is that happening, but they're also at risk for infection because they have a suppressed immune system. So you want to watch out for that as well. And some drugs that are included in our corticosteroids that may be ordered for RA are like dexamethasone, also called Decadron. Also methylprednisolone, which is also called Medrol, along with another one called prednisone. Then we have our last category of drugs for RA, and this is called the DMARDs, and it stands for disease-modifying anti-rheumatic drugs. And how do these drugs work? They work by suppressing the immune system and helping slow down the destruction of the disease. So they're a little bit different than the NSAIDs and the corticosteroids, which really just targeted that inflammation. This is really going to suppress the immune system so you don't have the white blood cells attacking the synovium. So what drugs are included in this category? One type of drug is called hydroxychloroquine, and one thing you want to watch out with this drug, and you want to educate the patient, is that they could have vision changes. So report that to the physician immediately, because it can cause retinal damage. Also, leflunomide, methotrexate, and sulfasalazine are included in that as well. Then we have a different category of DMARDs. It still falls under DMARDs, but they are called the biological response modifiers. And these drugs are genetically engineered, so they're used in those most severe cases. And some drugs included in this category are like abatacept and adalimumab. And Again, all these drugs are going to really suppress that immune system. So you want to educate the patient that because the immune system is being really suppressed, they could be at risk for rare types of cancers. Also, they don't want to receive any types of live vaccines because that is the live vaccine in there, and if they get it, their immune system isn't as strong and they could get the disease. And they want to let other members of the healthcare team who are taking care of them, like other physicians they have, not order them that. Also, they want to avoid infections, so hand washing is crucial, avoiding going out with large crowds of people, especially during the flu and pneumonia seasons during the winter, and avoiding having sick people come and visit them. And these drugs are given usually by injection, so it's common to see a site reaction at the injection site, so let the patient know that. And that it's crucial that they keep their appointments for blood work because they'll be having regular blood work to monitor their blood count, especially that white blood cell count. So let them know these appointments are very important because we want to make sure your white blood count is not getting too low. Okay, so that wraps up this NCLEX review over rheumatoid arthritis. Thank you so much for watching. Don't forget to take the free quiz and to subscribe to our channel for more videos.